Okay, hi everyone. Welcome to a day on neurological disorders. This will be the first video. And we're going to talk about only a handful of neurological disorders. There are many, many we could talk about because when talking about neurological and neuropsychiatric disorders, there's many that we could have talked about. There's entire courses that are just devoted to all these different kinds. So for example, there are things like schizophrenia, bipolar disorder, depression, PTSD, eating disorders, ADHD, borderline personality, OCD, so on and so forth. And so unfortunately, we're obviously not going to be able to talk about all of them. So I thought I would just pick a few that we would talk about in depth. But before we get to them, I thought I would just say a little bit in general about neurological disorders overall, just to give a little bit broader context of their importance. So one is that they are surprisingly common. About 1 in 5 people in the world have some diagnosable neurological disorder in some form or another. And, there's well over 5 billion people in the world. I think, what is it? There's like 7.5 billion. In which case that means there's over 1 billion people in the world who have some sort of diagnosable disorder. Now, some of which are very, very manageable and are minor cases and things that people are able to live with quite easily. Some, of course, are obviously much more severe and debilitating. And in that context, when you think about it, it actually turns out that luckily, or unluckily, depending on how you see the glass is half full or half empty, while 1 in 5 people might have some sort of a disorder, it is only considered disabling in 1 in 20. But again, 1 in 20 is still a relatively high percentage of people for whom their neurological disorder will have some sort of disabling aspect in their life. And then lastly, they actually generally occur and get initially manifested relatively early in life. So by age 14, about half of all diagnosable neurological disorders will have made an appearance. By age 24, about 3 out of 4 people who will eventually get diagnosed with some disorder, or 75%, will make an appearance. So just a little bit older than where you are right now is when they start to initially pop up. Now, one thing that I think actually surprises a lot of people when I tell them this is that the United States actually spends more money on treating mental health conditions and neurological disorders than it does on heart disease or cancer. Heart disease or cancer are 2 major focuses of United States medical expenditures, but actually the United States, through the National Institutes of Mental Health, spend more money actually treating mental health disorders than these 2 prominent physical disorders. And it has been estimated that neurological disorders cost our economy something around $317 billion a year. That comes in the context of medical costs, debt people go into getting treated, lost production hours, because if people are unable to work because of these sorts of disorders, that gets factored into these types of equations. I don't really know how these sorts of equations are tallied. Medical experts and economists work together to make these estimations. So I don't really understand how that works, but I know that that's the basic idea. Now, it's interesting because if you were to ask the question about, is our ability to treat people in terms of physical health getting better? In a lot of respects, the answer is definitely yes. Infant mortality rates are going down. Cancer prognoses are going down, or I guess improving. So if you get diagnosed with cancer now, your prognosis in terms of your long-term prognosis is better, and you have a greater probability of living longer or being cured than you did, say, 10 years ago versus 20 years ago versus 30 years ago, and so forth. The quality of life for people with HIV/AIDS is increasing, and with proper medication, actually, people who are diagnosed with HIV/AIDS now, their life expectancy would be no different than an individual who does not have the disease, because the medicines, while they can't cure it, can manage the symptoms quite well if properly treated. Heart disease and treatments are also improving. I believe that heart disease is still the #1 killer in the United States, but it is getting, hopefully, luckily better and better all the time. When it comes to mental health, however, unfortunately, the same really can't be said as it is with physical health. So the best way to sum that up is I actually found this quote by a man named Thomas Insel, who is the director at the National Institute of Mental Health. He's really the guy in the United States that is in charge in the federal government of directing funds for research to treat mental health and find cures and treatments and so forth. And so here's a quote from him that he gave in 2017, right as he was leaving NIMH. I spent 13 years at NIMH really pushing on the neuroscience and genetics of mental disorders, And when I look back on that, I realized that, well, I think I succeeded at getting lots of really cool papers published by cool scientists at fairly large costs, I think $120 billion. I don't think we moved the needle in reducing suicide, reducing hospitalizations, improving recovery for the tens of millions of people who have mental illness. I hold myself accountable for that. So unfortunately, it is the situation where actually the treatment and prognoses of mental health disorders are not getting better as quickly as you'd think, and some would even argue that in certain domains they're not getting better at all. This is not necessarily the case everywhere, but a lot of the things that are used to treat now, so medicines for depression, medicines for schizophrenia, they've been around for quite a while. We haven't really had major improvements on them in quite a while. And of course, one of the most unfortunate aspects of mental health and neurological disorders is that it is unfortunately stigmatized. But luckily, I believe that the stigma is going down with increased awareness and education. And if you talk to your own parents, maybe they might even be able to shed some light on the differences in how people view mental health now versus when they were in college, or if you talk to your grandparents, even more so. And so I believe that it's pretty clear that while it's of course not been totally understood and accepted, there is certainly an increase in acceptance. And so there's now, public health campaigns or public health campaigns that you can find where, people talk about advertisements where they say things like, imagine if you got blamed for having cancer, which is pushing back on the idea of blaming individuals who say are suffering from things like schizophrenia or depression or anxiety, of trying to change the conversation so that it's viewed not as, somebody's fault or a decision that they made, but that in fact, it is a biological disorder, a neurological disorder, in the same way that cancer is a biological disorder. This is a cartoon from The New Yorker where it's kind of pushing back on this idea by also saying, like, oh, geez, cheer up. Have you ever tried not being in a coma? Of course, it sounds somewhat ridiculous to, hey, maybe you could just get out of your coma if you work really hard at it. Similarly, as this idea that for a lot of neurological disorders, since underlying neurobiology is a biological system, sorry for the misspeaking, a biological system altogether, this idea like, oh, if you just tried harder to not have one of these disorders, maybe you could do it. The understanding is like that's a kind of as silly of an idea as suggesting to someone maybe you could just get out of a coma. So definitely one underlying theme that I hope really gets across to you all from these lectures is this idea about mental disorders as neurological disorders and, in a sense, biological disorders as they were. And one of the first ones we're going to talk about that I think is a great example of that is schizophrenia. Schizophrenia, unfortunately, is very heavily stigmatized, but hopefully I can show you some data that will give you at least an understanding about how I think it's very largely misunderstood and give you a sense of how scientists are looking at the underlying biology of it. So we'll talk about schizophrenia, depression, anxiety. Then we'll do something a little unrelated and talk about CTE and closed head injuries. I think a lot of people probably have heard about this specifically in the domain of football. So we'll talk to you about what it is and how it's understood. And then we will end with something that's somewhat related, which is dementia and Alzheimer's. The reason I say these two are related is because actually the symptomatology and the way that they manifest in the brain are surprisingly similar to one another, even though one group, for example, like football players, are often very young and healthy, whereas individuals who have dementia or Alzheimer's are usually much older and not as in good health. Okay, so let's dive into talking about schizophrenia. So what is schizophrenia? So schizophrenia is a disorder that is defined by positive symptoms and negative symptoms. Now, positive and negative in this case doesn't really mean what I think it's what it would intuitively seem like, which is like good symptoms and bad symptoms. It actually is referring to the presence of a symptom, that's a positive symptom, or the absence of something, that is a negative symptom. So for example, a positive symptom example would be delusions, so false or irrational beliefs maintained despite contrary evidence, or hallucinations, these sort of false imaginary sensory experiences that occur even though there is no external objective source from it. And then in addition is the presence of very lost and disorganized thoughts, of the idea of your mind sort of bouncing around. And so in these cases, it's the idea of there's a kind of a cognitive feature that is being added to a person who is schizophrenic. And so this is the idea of positive symptoms. And then on the flip side, negative symptoms or lack of certain cognitive functions are things like a flat or blunted affect and apathy. People with schizophrenia, they don't seem particularly emotional. They are not very easily roused. They don't get much joy out of many things. And that's what I mean by a blunted affect and apathy. They have a decrease in their attentional capabilities. They struggle to pay attention as much as other individuals did or before the onset of their symptoms. Limited or toneless speech. They don't really have, a lot of energy and excitement and passion in their voice. It's a much more limited, toneless, flat sort of affect. So it's very much related to these emotional descriptions up here. And then related to that is also social withdrawal, that they are usually much more reclusive and much more socially isolated, where you can have people who before their onset were very dynamic, passionate individuals, very sociable, like to go out with friends, and interact with other people. Then it becomes a more flat affect, and they will kind of become a little bit more reclusive. So how do you diagnose schizophrenia? So schizophrenic diagnoses are based primarily on observable behavior, but they are not currently it is not currently diagnosed on biomarkers. Maybe one day in the future, some of the things I tell you about will be able to, but as it stands now, it comes from assessing a person's behavior and actions. It is not the sort of thing where you can do a blood test or a brain scan like you could for something like cancer, a brain tumor, or some sort of, virus or something like that. And in fact, actually, usually when people are doing these diagnoses, there's greater emphasis that is put on the positive symptoms as a diagnostic criterion. When I was talking about the negative symptoms, for example, I've had students note before that, Professor Cohen, it actually sounds like you're describing someone who has depression. And so that's true. People who are depressed could have a flatter affect, more toneless speech, more apathetic behavior, more social withdrawal. So that's what, but people with depression, they don't have things like auditory hallucinations, for example. And so usually it's the presence of those positive symptoms that are the key for diagnosing someone as being schizophrenic. Now, before we go on, I really would like to emphasize some aspects of schizophrenia that are common myths, and that people have an unfortunate view towards schizophrenia that is just not true whatsoever. So one myth is that people with schizophrenia have multiple personalities. I think sometimes people actually confuse this idea of multiple personality disorder with schizophrenia, and that is certainly not the case. They might hear other voices, they might have certain sorts of conceptions that there's other people present that are not necessarily there, but that doesn't mean that any chance they have multiple personalities. One of the biggest myths actually is that people who are schizophrenic are all violent. That is certainly not true. Are there times where someone with schizophrenia can be violent? Sure. But are there times where people without schizophrenia can be violent? Absolutely. So actually, it's not really the case that people with schizophrenia are by any means overall as a group more violent than other groups of people whatsoever. Another myth is certainly that it's only about the delusions and the hallucinations. I think because of the fact that they're the most prominent symptoms and the ones that are the easiest to notice as being a little different than other sorts of, there's a lot of reasons why people might be socially withdrawn. There's a lot of people reasons why people might be, a little more blunted or muted in their affect. There's not as many reasons why people might have delusions or hallucinations. And so I think it's easy to think that those are really the only aspects of schizophrenia, when in fact there are other ones as well. And then one of the most important myths, I think, is this idea that there are no treatments whatsoever. This is also not true. There are a lot of people who are living with schizophrenia, who are very high functioning, who are successfully treated, and modern medicine has really helped them out. So it is certainly not, an incurable or untreatable, I guess it isn't really curable, but it's not an untreatable disorder. And actually, some people are surprised to learn that it is surprisingly prevalent. Between 0.5% and 1% of people, at least I know in the United States, I'm not entirely sure about the rates across the globe, have schizophrenia. And if you think about it, there are, at any given time, 1,800 Amherst students. 1% means about 18 students. So that means that there are anywhere between, let's just say like 5 to 20 students at Amherst at any given time who either have schizophrenia or more likely are about to develop schizophrenia because the onset is a little bit later in life. Okay, so what causes schizophrenia? So there's thought to be many potential causes. The biggest one, of course, are genetics. And so, for example, here, if you look at the schizophrenia risk for twins of those diagnosed with schizophrenia, so what this vertical bar is basically saying is, if your twin has schizophrenia, what are the chances that you're going to develop it? And this is looking across a bunch of different countries, which is just good because it always shows that it's a a more prominent, a more prevalent thing across cultures altogether, not just, for example, in the United States. You can see that the likelihood that you'll develop schizophrenia if your twin does goes up much more if it's an identical twin than a fraternal twin. So the fact that there's this major difference between identical and fraternal twins shows that there's some underlying genetic biological predisposition that makes you predisposed to developing schizophrenia. So genetics are definitely thought to be a big part of it. This is also shown if you look at not just identical twins, but you can look at a bunch of other sort of relationships, identical twins, individuals who have two parents with schizophrenia, your fraternal twin, your sibling who is not a twin, your niece or nephew, spouses, and so on and so forth. And basically all this data is showing, if you look at this slope, is the more closely someone is genetically related to a person with schizophrenia, the greater the risk will be that he or she will develop schizophrenia. So if your identical twin has schizophrenia, there's a good chance you will. If both of your parents have schizophrenia, there's a good chance you will. But if your sibling develops schizophrenia and your parents don't have schizophrenia, it's much less likely. And then, if it's someone like your spouse who is basically not genetically related to you, you see that it's even less likely still. So genetics are definitely a big part of it for sure. But there are definitely other factors that have been linked with schizophrenia also. So one is low exposure to vitamin D prenatally. So if a fetus does not get adequate vitamin D intake while it's in the womb, they are at a greater probability of developing schizophrenia later in life. Childhood trauma has also been linked to later onset of schizophrenia. We'll talk in a second about how could that be that something as external as childhood trauma could lead to something that is neurobiological like schizophrenia. So just hold that thought. Early nicotine use increases the chances later in life, and certain viral infections as a child have also been shown to increase the chances of developing schizophrenia later in life. So this issue, though, I want to stress about, for example, something like childhood trauma, there's this idea that the disorder will become, quote unquote, unmasked by adverse or stressful events during childhood. So the idea is that what could be going on is that factors on the previous slide can tip the scale for people who were predisposed to developing this disorder. So let's imagine that you have someone whose genetics are, it's not, binary, like they're going to develop schizophrenia or not. Their genetics are putting them at a high risk for schizophrenia, but it might not necessarily be certain. That person, if they go through a traumatic event, for example, that could, as it were, sort of tip the scale to a certain degree to make it more likely that they are going to now develop schizophrenia. So there can still be an underlying genetic factor that predisposes them and biases them towards eventually developing it. But it's this sort of interplay between the external factors and the more innate biological factors that can actually interact with one another. That's similar with things like nicotine use, for example, can also probably going to push the scale over for someone who naturally has a predisposition. Maybe they have a sibling who has schizophrenia or one parent, and that can kind of exacerbate the underlying genetics a little bit more. Okay, so now let's talk a little bit about schizophrenia and the brain. And one thing I really want to stress before we dive into this is that where we are in terms of the history of understanding schizophrenia in the brain is really still in the early nascent stages. And so what I'm about to walk you through is honestly more of a collection of results than a generalized overarching theory of schizophrenia. So if they seem a little unrelated to one another, you're right, they are, because we haven't really figured out how to put these disparate pieces together. But when you think about it, if you were going to start studying schizophrenia on your own, knowing nothing, you would just start to survey the land and survey the brain and see what you can start to find. And if you find something over here and something over there and something up there, you start to try to, over time, put it together. We haven't really figured out how to put it all together yet, but I still will tell you about some of the things that have been pretty well established. So one definite thing that is thought to be related to schizophrenia is what's called an overactive dopaminergic system, which basically means that the system in their brain that produces dopamine is overactive. There's too much dopamine in the system. Now, this might be confusing to some of you because you might think, well, isn't dopamine related to things like pleasure, perhaps even love? Isn't dopamine related to, we talked about this a while back, gosh, when was it? Week 2, week 3, when we talked about cocaine and how it affects dopamine receptors. You're right, but so it is a little complicated and a little tricky, but this is why I've been telling you all, since the beginning of the course, remember that neurotransmitters can be playing a role in multiple different functions. If you think of a neurotransmitter like a key, it's a key that it can fit in a bunch of different locks in a bunch of different systems. So it actually, this isn't, It might seem a little unrelated, but that's just because of the multifaceted and complex type of nature of these different neurotransmitters. So one is an overactive dopaminergic system. Another is related to these things in the brain that are called ventricles. So we haven't really talked about them, but I bet some of you have noticed that when you look at an MRI scan, you can kind of see these almost like dead zones in the brain. And here's just another look at what these ventricles look like. These ventricles are actually, they are sort of dead zones, but they're not empty. They're filled with cerebrospinal fluid. And they're kind of this center part of the brain where now you can see that the fluid would be able to go down and drape down into the spinal cord and so on and so forth. And so this is just sort of a hollow thing where the pressure is maintained to keep your head, or your brain rather, within your skull in a pressurized way. Turns out that with schizophrenia, a thing that you can really see sometimes with individuals just with the naked eye when you're looking at people with pretty severe schizophrenia, is that they will have enlarged ventricles. And so, for example, here is the typical ventricles of a non-schizophrenic brain, and you can just see they're kind of swollen and enlarged in the schizophrenic brain. So this is just a cartoon. So to give you a sense of what it looks like, this is a healthy brain here, and this is the slice of a schizophrenic brain. And so what you can really just see, this is what I was saying about with the naked eye, how you can just notice that on the left, there are much, much larger ventricles than there are on the right. Now, one thing, though, I really do want to stress is that, and this is really interesting, with these two images right here, these two people are identical twins. So this is why I was saying that if your identical twin has schizophrenia, there's a greater probability that you're going to develop the disease yourself, but it's not in any way a certain thing. Where you can see that this twin did develop it and this twin did not. And it could be because of, slight differences in the way certain genes were expressed as they developed. It could be because of external factors. Maybe this, twin was smoking and, had a much higher intake level, and that's what biased them in one case and in one direction towards developing schizophrenia, not the other. So this is what I meant by the kind of interplay between internal and external factors. But if you're wondering then why is it thought to a certain degree that increased ventricles are related to schizophrenia, it's really actually the idea is that the increased ventricles are kind of a symptom or a sign of atrophy of numerous brain regions. As your skull doesn't change in size, your skull is a fixed volume. But as, say, for example, gray matter deteriorates for whatever reason, what will happen in your brain is that the cerebrospinal fluid levels will alter, as it were, so that your brain stays in a nice pressurized, at the right pressure, kind of encased environment. And so even when your brain is deteriorating in that way, the ventricles and the fluid will kind of fill that empty space to keep it in a nice pressurized space. And so it's really not about the ventricles per se, it's almost about the ventricles as being a hallmark of the deterioration and atrophy of many brain regions. But I mentioned gray matter in particular because it actually has been shown that gray matter does decrease in individuals with schizophrenia. And so what you can do is you can scan people and you can actually delineate the border between gray matter and white matter. So here, between these green and red lines, that is where this program that works, it's extremely complex mathematical and computational work, but it differentiates between the gray matter and white matter boundaries. And this arrow here is trying to indicate the thickness of the gray matter. So it's actually literally measuring the gray matter thickness. And what you can do is you can look at how gray matter changes in typical development and in schizophrenia patients. So in this case over here on the right, these greens and red colors are showing larger annual loss and decreases in certain gray matter relative to normal adolescents. And I just want to point out, if you look at this, because we're going to talk about it in depth in a second, is in particular this idea of the frontal lobe, the temporal lobe being particular regions that are affected. You can't see it from this angle, but the occipital lobe less so. And I want to go back real quick before we go forward to talking about this idea about increasing acceptance and this, statement about, geez, cheer up, have you ever tried not being in a coma? You can imagine that if, this is related to the context of schizophrenia, it's like, hey, geez, have you ever just tried increasing your gray matter thickness? So this is kind of what I was talking about, how these, a disorder like schizophrenia, which unfortunately is very negatively stigmatized. I think it's important just to remember that we can really see that this is a biological thing that's going on. It's literally brain deterioration in, frontal temporal lobe. So in the same way that we think about a person in a coma or cancer or heart disease as having a biological problem, I believe that we should view schizophrenia similarly. So like I mentioned, the frontal and the temporal lobe, you can see some deterioration. So let's focus on those two in particular. And one thing I'd like to just really point out is that you can actually see in a healthy twin in a schizophrenic individual that there's a lot less activation in the frontal lobe in a schizophrenic individual. And we've learned a lot about the frontal lobe, so hopefully it will make some sense for when I talk about how this is thought to be linked to schizophrenics sometimes having difficulty inhibiting behavior. There's less gray matter, there's less activity, they might not have as much control of their behavior, especially in social situations, as individuals who have a more healthy functioning frontal lobe. Similarly, you can also see that there's a lot of decrease in activation and disruption of the circuits in the temporal lobe. Now, we've talked a lot about the temporal lobe, specifically in the context of audition, specifically in the context of language, and this frontotemporal connectivity. And it actually turns out that this deterioration of these frontal and temporal regions correlates and corresponds with auditory hallucinations. I think part of the idea that people think that there are problems in particular with hearing voices, hearing sounds, having those sorts of hallucinations is because as these brain regions deteriorate and the circuitry kind of just crumbles, for lack of a better word, it will malfunction, it will misfire, and people will have hallucinatory experiences. Just for the sake of time, I won't go into it in too much detail, but there are studies actually where a person who is schizophrenic could be in a real-time fMRI machine. So this is one where you can really look at a person's brain activity in real time. And what you can do as the experimenter is you can talk to the person in the scan and be like, did you just hear something? And the person will be like, whoa, how did you know that? And it's because you can see this activity in their auditory cortex. So again, it's not as if they're making it up. It's literally that their brain is misfiring, and that is leading to the hallucination. And it's something that as a scientist, you can see happening in their brain in real time. So we'll talk just very briefly about the treatment of schizophrenia. And I just want to give you a little history of it because I actually think it's very important to realize where we are now. Maybe this will also give you a better understanding about why I think it's so important to talk about things like acceptance of these disorders, is that the history of schizophrenia treatment is very, very sad. So in the early 20th century, 1910, 1920, 1930, there really was no actual treatment. Honestly, if people were diagnosed with schizophrenia, all that could be done is that they would just be institutionalized to try to keep them in an environment where they wouldn't, unfortunately, or accidentally harm themselves or others. And in the 1930s or so in the United States, so before World War II, the doctor-patient ratio was about 200 to 1. So for every 200 patients, I think I messed that up, the patient-doctor ratio, was 200 to 1. So for every 200 patients, there was really only one doctor. So in that situation, the goal of the treatment, that when they were trying to figure out what they could start doing, was to subdue these patients who might be having delusions, might be paranoid, might sometimes behave erratically. The goal at that point was we got to just figure out a way to keep these people calm. That's priority number one. We're not going to be able to find a cure or a medical treatment if we can't even get the situation more manageable. When you have 200 patients for every one doctor, you can kind of understand why that would be the primary goal. And so initially, the first treatment was a transorbital lobotomy procedure. And so the way that this would work, I don't really like showing videos of it because it's pretty intense, is you take this little thing here, I don't really know what it's referred to, the orbitoclast? Yeah, the orbitoclast. And it's almost like an ice pick, and you would lift your eyelid, or the patient's eyelid, and then you would stick it under the eyelid and go through, you would hit it with a hammer and go through the frontal part of the skull. And you would literally, not making this up, you would basically swirl it around in their frontal lobe. And what would happen is by, altering the connections of the frontal lobe so much, naturally there were a lot of side effects, but a big one was subduction, or subduing the individual. So people who might be behaving more erratically, they would become much, much calmer. Of course, as you can imagine, there were many situations in which they became effectively like they were in a vegetative state, they were unresponsive. So it's a very dark point, or a dark chapter in the history of medicine. But interestingly enough, it actually was considered for many years a huge success in the medical field, because people were like, we are literally dealing with hundreds or thousands of these patients with schizophrenia in this hospital. We're understaffed. These people are, violent and erratic and, sometimes paranoid and so on and so forth. And now we have a simple procedure, takes about 10 minutes. And now they're much calmer. They'll, we can get them to eat, so on and so forth. Sometimes it goes really bad, unfortunately, but that's true with surgery and treating anything. Interestingly enough, actually, the people who developed this, or the person, I can't remember if it was one person or multiple, actually, I think it was one person, won a Nobel Prize in medicine for this treatment. Of course, we do not do transorbital lobotomies now. And of course, in fact, we look back at it as viewing it as a little bit barbaric, but at the time, I hope you can understand why this is what people were trying to do, because in their mind, they had no other option. They were just trying to keep their head above water. So more modern treatments, luckily, are not focused on things like, let's just swirl an ice pick in people's frontal lobes. Instead, they focus on things like the dopaminergic system. So for example, since I was telling you early on about how the dopaminergic system is overactive in schizophrenia, people had this thought of, well, if there's too much dopamine, maybe we could develop a drug that will effectively block the dopamine receptors. And there is a drug that does that called, I always struggle to pronounce this, chlorpromazine. So what chlorpromazine does is it binds to the postsynaptic dopamine receptors, and it basically then blocks the ability of the dopamine to activate them. So even if there's a lot of dopamine in the system, the chlorpromazine will kind of get in the way to sort of lower the amount that dopamine is actually able to affect what's going on in the brain. So chlorpromazine, I think, is one of, if not the most common treatment because of its dealing with the dopaminergic system. And then the other treatment actually for schizophrenia, one of the big ones is talk therapy. Working with people who have schizophrenia, trying to get them to understand the disease, trying to get them to understand their symptoms, trying to work with them to understand you're going to hear voices, you need to ignore them, you're going to do these things, you're going to experience these things, it's okay. I think that you can find videos on YouTube. I'd recommend you watching some of them about people with schizophrenia talking about it, and how after a while they kind of get used to hearing these voices. They know not to pay very much attention to them or get too distracted by them. They'll pick careers where they might be in a more manageable load. So for example, if you were schizophrenic, I don't know if this is exactly right, but you could imagine that, for example, working in an elementary school with kids running around, there's voices all the time, that might put you in a different situation in terms of how easy it is for you to navigate that situation than if you're working in a quieter office where you have a little more control over the input, you have a little more understanding of the sensory situations and so forth. Okay, so why don't we take a little break, and then we will move on to depression and anxiety, and that's what we'll talk about for the second video.